different types of mental retardation. It's not, anyway. So, dwarfism is a condition of short stature. I'll put this in here though, just for the conversation. It is defined by the advocacy group Little People of America as an adult height of 4 feet 10 inches or under. And again, it can be secondary to medical or genetic condition, much like the ones that we listed earlier. There are other groups out there that may have kind of a play on that number, basically 4 feet. Of course, they can be shorter than that, right? But that's your kind of cutoff. There are 2 main categories for dwarfism. This would be important to know. This would be a great test question. There's disproportionate and proportionate. And once you kind of read these definitions, you'll probably be like, yeah, now that if you know anybody that is of short stature, you could tell the difference in between their torso being elongated and short limbs, or if they're just short proportionately. And I've actually known a person from each one of those categories personally. Anybody in here have a family member or someone they know either proportionate or disproportionate? No? So disproportionate dwarfism is characterized by an average sized torso and shorter arms and legs, or the reverse, shortened trunk and long. The individual that I knew had a quote-unquote normal sized trunk and shortened arms and legs. Proportionate, again, is what I said a few seconds ago. They are small, all of them. So they're in proportion to each other, but just shortened. Please know that. Causes of proportionate dwarfism include metabolic and hormonal disorders such as growth hormone deficiency. So again, it's a long list. I wouldn't ask you something that specific. In regard to disproportionate, skeletal dysplasias are the most common cause, and it's basically abnormal bone growth, and it has a genetic component. Now the next couple of slides are the most common types of dwarfism. The most common form of dwarfism is achondroplasia. You've probably heard that word before, medical term word. It occurs in about 1 out of 26 to 40,000 babies, and it's evident at birth. People with achondroplasia have a relatively long trunk and shortened upper parts of their arms and legs. These are some more specific signs and symptoms for achondroplasia. Large head with a prominent forehead, flattened bridge of the nose, protruding jaw, crowded misaligned teeth, forward curvature of the lower spine, bowed legs, their legs are bowed out. Flat, short, broad feet, and they have issues with their joints, they're double jointed. I'm totally like shooting at the hip here, I'm sure we can look it up. Anybody here watch Game of Thrones?
Yes.
So I think that's probably, just by reading, is why everybody else, what's his name, Tyrone, what's his name?
Tyrion.
Tyrion. Knowing those names is like, you'd have to have a PhD to write it. I don't know, I think about him when I read this description. I don't know if that's what type he is. But his legs are bowed. If you've ever watched that show, you know I'm talking. He was actually on Nip Tuck a long time ago, if you ever watched Nip Tuck. He has the bowed legs. He has this really flattened, broad nose. And he does have a bit of a protruding jaw. So, if you need a visualization. Google him.
That is
his
what he
name?
has.
Huh?
He
Is
does
it
have
a-
those.
Okay, what's his name? Real life?
Peter Dinklage.
Dinklage. I don't know if I've ever heard his name before. But,
Yeah,
okay.
yeah. Yeah.
Interesting. Okay, cool. Least comments, we're kind of going in order because I do believe I have, yep. So 3 types. The first one, achondroplasia. This is the next in line. SED. Not even going to try to butcher it. It's less common. Obviously, 1 in 95,000 babies are affected. This one's interesting in that the shortened trunk may not become apparent until later, 5 to 10 years of age. But at birth, you would know there was something not proportionally correct. These are some additional signs and symptoms that you may see with SED. The last, the most rare form is dystrophic dysplasia, 1 in 100,000 births. They're interesting in that their forearms are actually shortened. So their hands are in this, they're not where they should be at the end of the forearm. This can also affect their calves as well. There are additional signs: deformed hands, feet, limited range of motion, cleft palate, and they can have, their ears can have a cauliflower appearance to them. A potential question might be, what is the most common form of dwarfism? So diagnostic workup, this can be pretty intense actually in regard to it, because if it is a growth hormone deficiency, let's say in an older individual, there are many things you're going to work on that for. Anyway, this first bullet here basically is a repeat of what I said. We don't just go straight after growth hormone because of, again, it is too pulsatile, it's too erratic. You may not be able to get a good number on it. There's indirect hormonal criteria and direct hormonal criteria. The IGF levels from a single blood sample, or you can do growth hormone in multiple blood samples. The literature that I read, you can do both. Some people, again, lean more towards IGF levels because of, again, the difference in the growth hormone being changes. But if you were set up on a really strict regimen of doing blood draws, you could absolutely do the direct hormonal. But again, the main article, because even in your book, it didn't really, if you've read your Greenspan, it doesn't specifically say one or the other, that they can be used together. You can do them in conjunction. Another thing that can be utilized in growth hormone deficiency is provocative test. Provocation is actually another way to say it. That's much like the glucose that you do. You give somebody something external, they put it to their body, and you see if it does something to another chemical. Either increases it or suppresses it. And that's essentially what it's saying here. You essentially give them a dose of an agent because you want to see if they can release the growth hormone. The agents that you can utilize are bullet point number 3. levodopa, clonidine, I couldn't believe clonidine, I did not know that. Epinephrine, propanol, so beta blockers. Glucagon, insulin. So you give them a dose of any one of those agents. And then small amounts of blood are drawn at 15-minute intervals. And you want to see if their GH increases. If it does not increase, you know something's got to be going on with blood. Yeah, it could be the pituitary. Exactly. Could it be potentially more upstream? Because that's a primary, right? What would be a secondary? Have you learned primary deficiency versus secondary deficiency, tertiary? Because end organ, and you go to, I'm sorry, target organ, then you go to what is like the thyroid releases. But what actually affects the thyroid to release TSH, release T3, T4, right? But what affects the pituitary? Right, so that's why you have to do provocative test, because you want to see where the actual deficiency's at. Where's the level at? Majority of these individuals, though, it's actually deficient from the pituitary gland. The biggest thing in the literature that you're going to see for the kiddos, obviously you got to look at their bones, because they do have a lot of the dysplasia, the bowing, the changing in their bones, their plates, so plain films, DEXA scans, imaging is important. I'm just looking here. If you did think it was hypothalamus or pituitary, again, you always want to MRI the head. MRI the brain, I'm sorry. MRI is the best that you could do for the brain. MRI, MRI, MRI. If there's ever a question and it's in the ER, case vignette, answer CT scan. Don't ever answer MRI. But real, I mean, like if you could get the MRI, it's MRI. It's the best. You can, but it's because the workup of these individuals is pretty intense, unless a genetic, and this is again, because I believe you might have touched on this briefly in your genetics course. A lot of these are not isolated, especially if there is a familial or a genetic component. Mom and dad know, it's been seen, it's through bloodlines, so that's why we do genetic counseling in a prenatal visit or even before you get pregnant. So a lot of instances, it is known beforehand if there is a genetic component. Anyway, but much like the workup for it, the treatment can also be complex. Again, this would be an instance where you do want to pull from your other resources, and that's a pediatric endocrinologist. The biggest thing that they will do for your peds cases is administer growth hormone. They will give it to them. And again, much like with your other hormone deficiencies, if you do note, you have to replace those as well. So obviously growth hormone's not there. There may be deficiencies with other, depending on what happened to them, whether they're had trauma, they had radiation, whatever, pituitary hormone's not there, you have to replace it. There's actually pretty good evidence and treatment outcomes in kiddos with growth hormone. They will gain some hype on them. Just again, depends when you introduce it. Can you get them to come in on a regular regimen to actually have it administered? Can they be monitored appropriately? Does anybody know anybody here that's ever done growth hormone? Was it for short, or was it for like bodybuilding or muscle?
To increase height.
Oh, really? Was it a kid, if you don't mind me asking, was it a kiddo?
Yeah.
Or was it,
Yeah.
did it work?
Yeah.
Okay, that's awesome. How old were they when they started doing it?
I'm gonna say like somewhere between like 12 and 15.
Oh, wow. God, I wonder if I could start doing
It's too late for you.
this. That's crazy though, that it, I wonder, how much did they gain? How much had like, I mean,
I don't know, like, I just know that he was, like, him and his parents had discussed that he wasn't like, he was below average for his
Right.
height and he wanted to get taller. And so he did growth hormone and he's like 5'10" now. And he didn't like gain a lot of height, but I think they were projecting him at like smaller than that, I'm not exactly
right,
sure.
I got you, okay, cool, okay. That's interesting. Pituitary adenoma. You know, there are a lot of different types of pituitary adenomas that secrete a lot of different things. As you go through all of your other ClinMed lectures, you will hear pituitary adenoma secretes, prolactin secretes, corticotropin secrete, whatever. Pituitary adenomas are very common in regard to when there is an endocrinopathy, it's usually the culprit or the cause of the issue. Basic definition, because a lot of times we as practitioners and as students just go over the basic definition of what something is. Like if somebody said, what's a pituitary adenoma? You'd be like, I know what signs and symptoms are, but you need to understand what the basic definition of these things are. One, it's important, but also you have to tell somebody one of these days, what is that? What is a pituitary adenoma? You have to describe it to them. Typically, they are benign, like most of them, even for your acromegaly or your Cushing's or those other things. They are slow growing, and they arise from cells in the pituitary gland. They are the third most frequent intracranial tumor the individuals will encounter. I would know, out of all the different ones that are listed there, bullet point number 3, the most common one, which is colectinoma. That is the most common one. You can obviously read as you move down by the percentages from most common to least common, but I would know colectinoma as the most common. I would also know, how would you even define, because you'll hear macro versus micro adenoma. And again, it just goes on size. I would know what I've underlined there. Micro less than 10 millimeters, macro greater than 10. You can read the epidemiology there. Female's the only thing increasing, that's just for the micro. I wouldn't really so much ask you a pathophysiology question on pituitary adenoma, because that's kind of intense, right? Monoclonal adenopophyl cell growth. Hormonal effects of functional microadenomas, often called diagnosis or mass effect. Prolactin increased by functional prolactinomas or inhibited dopaminergic, I can't say that word, dopaminergic suppression by stalk effect. Those are some of the causes and what you see because of those causes. Basically, it's overgrowth, cell growth. But again, I wouldn't ask you a pathophysiology question on that for pituitary adenoma. Symptoms, things they're going to come in complaining about. Again, it depends on what it's secreting. Obviously, if it is prolactin, they are gonna come in with every one of those first bullet there. Infertility, amenorrhea, lactorrhea, gynecomastia, and having issues with impotence. Because when do we need prolactin? When does prolactin really increase in a normal woman's life cycle, I guess? When? When it helps with breastfeeding. We release oxytocin as vaginal delivery happens, contractions. Prolactin is released to help with breast milk production to be able to breastfeed, right? Right? So why would, if you had, it kind of goes along with that whole old wives' tale, which it can work if you do it correctly, but if you breastfeed, you can't get pregnant. You've probably heard or met people that have gotten pregnant by doing that. Because essentially, if you breastfeed round the clock, all those other things are suppressed, so you can't get, that's why, because they have too much of it, they don't have a period, they can't get pregnant. Does that make sense? Anyway. The headache and the visual disturbances, this is a repeat. It's because, again, of that pituitary, and that an enlargement in the pituitary gland. And again, if you know where it's at in the cell turrica and in relation to the optic chiasm, you know why you have those symptoms. Less common, you can read those. Again, these are all indicative of whatever hormone it's actually secreting. The most common one is prolactin, that's why it's listed as most common. And again, at the end of this course, you'll understand those symptoms better because you'll have had Cushing's, thyroid issue, you've had them all, so you'll understand what those signs and symptoms mean. I'm doing your Cushing's disease lecture, so we'll go over that later. Rare hyperthyroidism, issues with adrenal insufficiency, apoplexia. What does that mean essentially? Apoplexia. Does anybody know what that means? Basically decreased blood to it, so it doesn't really rupture, but it essentially just is no longer functioning. It's like an infarct for that organ. Which is not good. The last bullet point here is important in that if it becomes enlarged enough. So again, you have to think about brain relation and anatomy relation. If you have that pituitary gland, you know where it sits. The hypothalamus is up above. It gets big, 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 big. It can start to put pressure on your hypothalamus. And that's where you get really bad mojo, because of temperature regulation in the body, if you know what the hypothalamus does. Physical exam, so these are the things that we see. Again, visual disturbances, hypogonadism, so small testes, lactorrhea, so you can't see discharge from the nipples. Would it be unilateral or bilateral? It should be bilateral. Again, it's usually not affecting just one, because again, it's a systemic issue. It's not like a malignancy, breast malignancy, where you just have one breast. Gynecomastia, obviously they are secreting, like we've already talked about, acromegaly, too much somatotropins. You're going to have your acromegaly features. Less common, so again, you know what papilledema is. That's secondary to increased cerebral pressure, or ICP is increased cranial pressure. That's what it stands for. I apologize, I should have told you what that is. Physical exam signs continued. So if they do have a complete shutdown of the pituitary gland, you're gonna start to have the hypotension, the tachycardia, and things will start to shut down from there. That's why they have decreased urine output, because everything, and usually they, apoplexy is again because they are in a hypotensive state because of major blood loss. So how do we work this up? And again, probably wouldn't ask you a question from this section because it depends on what is being secreted. So if you thought acromegaly, you've already talked about that, you could go, you would know what to look up for that. What if you go after you look at your slides and memorize it? If it was a decrease in the somatotropin, kind of like growth hormone deficiency, that's how we would work it up. And again, earlier when I said I would never quiz you on levels, I wouldn't, but I would challenge you when you go and read and study, look them up so you can get a feel for it. It always helps, but again, these things are so not rare. Again, unless you go into these areas for endocrinology or pediatrics, these are not going to be blood levels you're going to be ordering regularly or ever. So I feel like it's a waste of your studying time to have you go memorize numbers. But still get a feel for it. Look it up. If you felt like you had too much cortisol with your Cushing's, which again, you'll get that lecture, so don't freak out, you'll put this on the back burner for right now. Because this is essentially how you work up Cushing's disease. They don't have enough cortisol. This is how you would work it up. And you're going to get this in your Addison's disease lecture, what that deficiency is. Let's say a tumor was found, incidentally, they just had an MRI or CT scan and a tumor was found, meaning they didn't have any symptoms that you saw because of a deficiency or an excess hormone-wise. This is a pretty good panel that you can order for asymptomatic tumors. But again, all of those were essentially in the last two slides. Again, if you know you have a family history of mutations that cause pituitary adenomas, you can do that in your genetic counseling or genetic testing if need be before pregnancy or your prenatal visit. It's kind of interesting because once it's at your prenatal visit, it's kind of right, you're already pregnant. So it's important to do it beforehand. MRI, again, is where it's at in regard to identifying because it can see, if it's a microadenoma, it can pick up to 2 millimeters in size. So teensy tiny. CT scan's not bad, but MRI's the best. The octreotide SynGraph is really interesting in that you basically give them octreotide and then you look for light up, receptor light up. That is something specialized that you would do in your endocrine practice or your endocrine reproductive practice. Most of the individuals that I dealt with, because I had a couple of patients that had pituitary adenomas, it was MRI, it was confirmed by MRI. I actually had a young lady came in that was probably a 21-year-old, she was early 20s, African-American female. Her main complaint was amenorrhea, she had Mr. Period. So I was putting her down, and the more I spoke to her, she started complaining of headaches. She didn't have visual disturbances by any means, but she did have headaches. So I ordered a panel on her and got an MRI. She actually had a pituitary adenoma. It was benign, but it actually had started to affect her gonadotropin axis. Treatment. Read these. Dopamine is what we use to suppress prolactin. If it is a prolactin you're secreting high amounts of it. Dopamine is the main thing that we give individuals to decrease that. Cabergoline is the main one. In actuality, that's the only one I know. Well, it's not true, no, these are what we've already reviewed in your acromegaly portion. You haven't gotten this yet because you haven't done your increased cortisol or decreased cortisol lecture. So don't worry about this tonight, this slide. You'll get more of it when I give you that lecture. There's a lot of medications for pituitary adenomas. Again, like if it is in your acromegaly case, if it is surgically resectable, that is the way to go. Because obviously if you go in, without doing too much damage to the other structures, you can go in and take it out. That's what we're going to go try to do. And again, this is the transfemoral approach where they go in through the nose and go in through. It sounds really crazy. Oh, Nikki was explaining it to me. I was like, oh, that's awful sounding. Indication, obviously symptoms. When else do we do surgery? Obviously, if there are contraindications to anything surgical, you can do medical management, pharmacotherapeutic management first. But if they are resistant to that, then you're going to want to go. And they just do a cost-benefit analysis to see is your quality of life more than the risk or vice versa. But most individuals will go in and try to have it removed. The young lady that I had seen, because I always read their notes, if you refer out most places, whatever, or whoever I refer her to endocrinologists. If they're a good provider, they'll send you their office visit, or you can call and get it to review. You know, what did you do? What did you talk about? Just in case they ever come back to your care. And she actually did not want to do surgery. She just wanted to wait. And she was young, and it probably scared her. I mean, that's scary, right? And she was not wanting kids yet. So she was going to wait a little long. Again, much like your acromegaly case, you can do radiotherapy. And again, that's just trying to blast it with a beam to try to shrink it. But again, that has its side effects as well. And it's not obviously as good because there's a lot of stuff you got to go through to get that beam, that proton beam, to where it needs to be. Neurosurgery consult referrals obviously important, other than endocrinology. And then ophthalmology is also important because you want to see if everything's intact before they go and try to remove it. But usually when they go in and take that adenoma out, it takes that pressure off the optic chiasm and they're fine after that. Prognosis, again, depends on many different factors and variables, size, type, and where they were at their treatment course. Complications, again, it's much like what we've already talked about. Anytime you go in and try to remove something off the pituitary gland, so teensy tiny, you always run the risk of damaging surrounding structures and causing deficits in those areas. That's essentially what those are saying there. And then obviously you don't have to worry about the optic eyes, because if you damage that in surgery, then that's not good. You will have permanent loss there, visual. Any questions over that component? I try to pinpoint to you some areas that you might want to focus on for your exam purposes, only because those topics, unlike Cushing's, unlike Addison's, those are very broad things, other than the acromegaly, but pituitary adenoma is pretty broad. It could be any one of those hormones, growth hormones, pretty broad. So I wouldn't ask you specific lab type stuff for those. Any questions about that? I know you guys are really tired. Why don't you guys take like a